It relates to what should we be telling patients to do when they have exacerbations at home, not at the doctor's office, not in the hospital, not in the ER. The goal of the recommendations being to help them regain asthma control without having to take steroids by mouth or injection, and without having to come to the urgent care or doctor's office. Doctor's office is also okay, but not the urgent care or hospital. The guidelines for asthma have traditionally been performed by the National Heart, Lung and Blood Institute, called the NHLBI guidelines. The most recent version, however, was in 2007. In the guidelines, they did not find any evidence to support any step-up therapy when the patients were at home, other than just using their rescue inhaler called short-acting beta agonists. And if that didn't work, do more of that. And if that didn't work, then you have to do oral steroids or go to your doctor. Since then, though, there have been some studies that have explored different options. But the guidelines have not yet been updated because it's a very complex process to do it. So the practice parameter is a group comprised of representatives from the two national organizations, the American College of Allergy and the American Academy of Allergy, and we meet and look at evidence and go through it and try to come up with recommendations to address these clinical problems. Needless to say, there weren't too many studies that look at asthma exacerbations because it's really hard to follow a patient over a year, get them in when they're sick, see what happened, what worked, and it's a very complex process. So there weren't too many studies that looked at that, but we looked at what we could find, and then we looked at studies that looked at other aspects of asthma but had this as part of it. So we sort of teased out the data from those studies and put it together and came up with recommendations. So the recommendations were that just relying on rescue albuterol or short-acting beta was not enough. It really wasn't shown to improve the asthma exacerbation. It didn't harm, it was helpful, but it didn't change the need for oral steroids. So that recommendation as a standalone didn't make sense. So we said it needed to be done, but not as a recommendation option. There are 2 or 3 new types of options that we thought might be helpful. One is to increase the dose of the inhaled steroids on patients already on it. So if you're taking an inhaled steroid twice a day, increase it by 4 times or higher. You can do that by either increasing the number of puffs, twice a day if that was a better thing, or increasing the number of doses. So if a parent was able to actually give it to the child, or if a patient was able to take it 4 times a day, that was also great. And stepping up to doses 4 times or higher seems to have a good impact on asthma and bring you back to control. And we recommend doing that for 7 to 14 days. Now 7 days for symptom improvement and 14 days to get the lung function back. The other option, this is applicable to patients who are very mild asthma, who may not even take a daily controller medication, but they have symptoms on and off. Instead of just using albuterol or a rescue inhaler when they're sick, we suggest that they piggyback an inhaled steroid to the rescue inhaler. That helps you also have an anti-inflammatory effect and gets the asthma under control better. And this was based on some studies that showed that this strategy worked in the really mild patients who were stepping down off their medications. And that's been studied also and shown. The third strategy, the same concept of piggybacking an inhaled steroid onto a bronchodilator, only this time the bronchodilator is a long-acting bronchodilator. Not by itself, but the combination product. So in asthma care, there are combination products which have inhaled steroids and long-acting beta agonists. That's called ICS-LABA. There's one type of LABA, long-acting beta agonist, that is rapid onset. So it acts as soon as albuterol does, but lasts for 12 hours. So that drug is called formoterol. So there are some combination products which have formoterol in it with the inhaled steroid. The inhaled steroid being budesonide or mometasone. There are some products like that in the market. So patients who are on that on a daily basis may consider stepping up to using that same inhaler instead of the albuterol when needed. So that is called single maintenance inhaler rescue therapy. So you use that for both maintenance and for rescue. It's also called adjustable maintenance dosing. That is a strategy, however, that has some drawbacks. The drawback is that use of it that way is not FDA approved. In fact, there's a black box warning that if you overuse the long-acting beta agonist component, it may cause harm, is what the FDA here thinks. It's been used in Europe and Canada as the treatment. So this strategy is very popular, and these studies are mainly based in Europe and Canada and have shown to be really successful. But in the US, there's concern about the black box warning and going against FDA recommendations. So that's why the strategy is not one of the top recommendations. We had to downgrade the recommendation, even though the evidence actually suggests it works very well, especially in adults. In kids, there's not enough data to support it.